very much for joining আজকের এই Mind Radiology and Cardiology session, which is a part of a series that we are planning. Sadia is planning really brilliantly about this exciting new brand, cardiac imaging, which আমরা আসলে ডিসকাস করছিলাম যে বেশ কিছু বছর আগেও আসলে আমার নিজেরও এত আইডিয়াই ছিল না কার্ডিয়াক ইমেজিং এর ব্যাপারে, এবং এভরিডে আই এম লার্নিং. I think all the cardiologists we are learning, and we are focusing more on imaging, which helps us to really plan our procedure, find the niches about little bits of confusion that we sometimes go through our coronary angiography. But more importantly, nowadays, the minimal invasive procedures, particularly the structural procedures, are intricately dependent on this cardiac imaging for appropriate planning. So এই সাবজেক্টটা আসলে এত এখন ওয়াইডলি পপুলার এন্ড ফাস্টলি ইমপ্লিমেন্টেড যে এটার গুরুত্ব বলে শেষ করা যাবে না। এবং আমাদের সাথে আজকে আমরা প্যানেলিস্ট হিসেবে পেয়েছি Professor Meshkat স্যারকে. Thank you for joining us, sir. Professor Meshkat Ahmed, sir, Department of Cardiology, BSMMU, and Scientific Secretary, Pulmonary Hypertension Support Group. আমাদের সাথে আছে Dr. Jahangir Kobir, sir. Sir, thank you very much for joining us. Sir, Professor Jahangir Kobir, sir, very well known to all of us, Chief Cardiac Surgeon and Director, Cardiac Center, United Hospital. আমাদের সাথে আছেন Associate Professor Dr. Nusrat Ghafoor Appa. She's Associate Professor and Consultant, Radiology and Imaging, Ibrahim Cardiac Hospital and Research Institute, Dhaka. And I'm excitingly introducing Dr. Ajoy Kumar Datta, Chief Consultant and Cardiologist, Al Haramain Hospital, Sylhet, and former Assistant Professor of Cardiology, Sylhet MEG, Osmani Medical College. Ajoy da সলিমুল্লাহ মেডিকেল কলেজ থেকে গ্রাজুয়েট করেছেন, এবং তারপরে উনি গত কয়েক বছর he got higher training in cardiac imaging both in UK as well as in India, and doing really an exciting thing in Sylhet, which we were just talking about. Thank you for joining us. I really appreciate all of you to be part of our panelists, and I will hand it over to Sadia now to start the session. And let me introduce Sadia. There is nothing to say about. She's one of the most brilliant radiologists, and that I'm learning every day from her. And she's currently acting as junior faculty at Massachusetts General Hospital, which is part of the Harvard Medical School. She moved from UK last year, right, Sadia? Former consultant radiologist of Royal Papworth Hospital, Cambridge, UK. So we're excited to have you on this side of Atlantic, and we are looking forward to learn from you today.
Can I take
you're muted.
Take a minute? With us, there is Professor Shajal Banerjee, who has joined with us. He is Professor
Right. So we have
German, and also we have Dr. Navin Sheikh. She is an Associate Professor of Originary Pediatric Cardiology. These are two faculty are from BSMMU, and there are many of our students are there.
Thank you, sir. Thanks for connecting me. Shajal Banerjee, sir, we are really grateful that you joined us today. And Dr. Navin, I'm glad to know you today. আমি আপনাকে আজকে আপনার সাথে পরিচিত হতে পেরে খুব ভালো লাগছে। আমাদের সাথে আছে আসলে এখান থেকে আরো আছেন ডক্টর নাসির খান আছেন, ডক্টর শাকিল ফরিদ আছেন, এবং আরো অনেকে আছেন। আসলে I am seeing there's already like 50 plus participants there. So if I'm missing someone, please apologize me. And Sadia, let's I think you need to unmute yourself.
Just sharing my screen. Can you hear me?
Yeah, we can.
Sorry, I had some technical problem. I was sharing from a different screen, and now, can you see my screen now?
Yes, we can.
Is it a bit better than the previous one I was showing?
I think so. I think I'm
Thumbs up.
saying আমি মানে পুরো স্ক্রিন জুড়েই দেখতে পাচ্ছি, so
আচ্ছা, ঠিক আছে। আমি যেটা বলতে চাচ্ছিলাম বাংলায় সেটা হলো, সরি আমি ভিডিওটা অফ করেছি, নাহলে আমি ডিস্ট্রাক্টেড হয়ে যাই। সেটা হলো, আমি এটাকে বলবো একটা লার্নিং সেশন ফর অল অফ আস, উইল বি লার্নিং ফ্রম ইচ আদার। অ্যান্ড আমার কার্ডিয়াক ইমেজিং এ আসার পেছনে ব্যাকগ্রাউন্ড হলো, আমি কখনোই রেডিওলজিকে ইন্টারেস্টিং সাবজেক্ট মনে করিনি বাংলাদেশে। যখন আমি ইংল্যান্ডে গেছি তখন মেডিসিন করতে করতেই আই গট ইন্টারেস্টেড ইন ইট, অ্যান্ড দেন ইভেনচুয়ালি কিছু ইমোশনাল রিজনের জন্য আমি কার্ডিয়াক ইমেজিং এ এসেছি। দেন আই স্টার্টেড টু এনজয়। তো রেডিওলজিস্ট যারা এখানে আছেন তাদেরকে বলবো যে সবাই ক্রস সেকশনাল ইমেজিং করেন। কার্ডিয়াক ইমেজিং হ্যাজ গট সাম specific, sorry, I'm getting some echo. Give me 2 moments. কার্ডিয়াক ইমেজিং এ একটা জিনিস স্পেশাল, সেটা হলো it has got some additional benefit. Give me 1 second. Can you hear my voice clearly?
সাদিয়া, তোমাকে দেখা যাচ্ছে না, তোমার
হ্যাঁ।
কথা শুনতে পাচ্ছি কিন্তু তোমাকে দেখা যাচ্ছে না।
আমি ভিডিওটা অফ করেছি বিকজ অ্যাকচুয়ালি আমার স্ক্রিনটা একটু অন্য জায়গাতে আছে, সো I'll get distracted if I want to look at the screen, that's why. আচ্ছা, আমি শুরু করি তাহলে। So I just wanted to say that Cardiac-CT is here, and first disclaimer is not to compete but to complement all the other imaging specialties or modalities and the patients, of course. So I don't have any disclosures. So the objectives of the session is, how do we do it and why do we do it? I will show some cases as well, and I'll discuss later on. We'll have a little quiz after that. So first thing is about cardiac CT is it has to be ECG gated. So the difference between other CTs and cardiac CT is it has to be ECG gated because it's a moving structure. So you have to take the picture when it is still. Maybe systole, it may be diastole. So most of the imagings are done in diastole because that's the most static phase of cardiac cycle, when you can capture the heart without motion. But to capture it in diastole, you may need to do pre-medication because heart rate may not be stable or low enough to capture the cardiac cycle. So most of the institute, they use beta blockers it may be oral or IV. And nitroglycerin is essential because we want to dilate the vessels to look at the lumen properly. So these are the two considerations you have to have before requesting cardiac CT. If it's very high rate, very irregular, with modern scanner, we can scan it. But what I'm going to do today, the session will be dedicated to Bangladeshi doctors. So I'll try to remember that not everyone is able to get a good scan with high heart rate because of the generation of scanner we have in Bangladesh. Here in MGH, we do systolic imaging. We never give any beta blocker. So we get through a lot of scans a day because we are not at the scanner, not preparing the patient. Our slots are only 20 minutes. The other consideration to have is breath hold. The cardiologist, if you request a cardiac scan, please train your patient to breath hold. It's only 10 to 15 seconds. But if the patient is too breathless or unable to lie flat, we cannot do the scan. Cardiac scan can be non-contrast, can be contrast enhanced. Sometimes for the radiologist who are joining here, we may need to do additional contrast. If the question is to rule out pulmonary embolism and coronary artery disease, then we add extra contrast to pacify right side of the heart. Field of view is important to remember because it all depends on what you request as a clinician. The radiologist will optimize the field of view. For example, if you want to see pulmonary arteries, pulmonary valve well on the same field of view, we extend it basically because I'll show you why. So how we do the scan is we get the scanogram first, the whole body, to position the patient, and it determines the dose it is going to give the machine. The scanner determines from the scanogram. So two reasons. One is anatomical information for the technologist and dose calculation for the scanner. And then we collimate it down to the heart. As you can see, can you see my cursor?
Yes.
Yes, we can.
Okay, thank you. So we collimate it down to the heart only. So we scan only this part of the body. But if you want us to scan CABG, then we will go all the way to the top because we have to see the Lima graft. Okay. Image acquisition, ECG gating is very important. Probably I will keep this slide for our next dedicated coronary imaging session. But briefly, we can do prospective or retrospective imaging. Prospective has got slightly lower dose than the retrospective ones, but sometimes we don't have any other options than doing retrospective. Can be modulated to lower the dose. The radiologists are more familiar with that. Retrospective gating has another advantage. If you capture the whole cardiac cycle rather than only the diastolic phase, you can have functional information. Contrast protocol is our aim is to opacify left side of the heart. So we put the ROI there, and when the contrast comes there, the scanner triggers. Sometimes we do bolus tracking as well. ECG gating is very important. If you want, as for the trainees, if you want one information to keep in your mind is ECG gating. So it's for aortic imaging. Suppose you have got a patient with the question of aortic dissection, it has to be ECG gated image because you can see the motion there. We cannot assess coronaries, we cannot assess aortic roots, any valves if there is motion artifact. And this is the ECG gated image. Look how crisp it is. You can see the outline so clearly. This patient was referred as aortic dissection from a different hospital. It happens in USA as well. I have experience in England and here as well. Patients have been operated on in terms of had median sternotomy because had chest pain, and the radiologist said it's aortic dissection from non-ECG gated images. So it happens everywhere. So be aware of that. So this is the way we do. We select which phase of cardiac cycle we want to scan, and then the scanner does the job. I will skip that. So phases of contrast, just very briefly, as you can see, this is...
Sadia, we lost your voice.
You lost my voice? Can you hear me?
No, we can hear you.
No.
We can hear you nicely. No problem.
We can hear you. Carry on.
Thank you. Thank you. So you
Can
can see
hear
the
you.
phases of contrast. So it all
We
depends on
lost your
which side.
voice. I think we need your...
No, we can hear you.
No, we can hear you. Mashrafi, I think it's problem with on your side. We can hear you, Sadia. Carry on.
Okay, thank you.
Yes,
So-
she's audible.
Sorry. My apology.
Sorry, probably network issue. So phase of contrast is so important. It's for the clinician as well, because when you request a scan, please specify what you are looking at from a cardiac scan, because you can see the opacification is so different in 3 different scans, right? So this is for the dedicated to the aorta and heart. This is dedicated to both sides of the heart, and this is probably would be dedicated to pulmonary artery. So we can have functional information. This is qualitative functional information that is derived from capturing whole cardiac cycle with dose modulation. So we can give you more information about wall motion abnormality if the patient didn't have echo before or echo window is very poor. This is mainly for radiologists, but I can tell you from that axial acquisition, we can make all these planes a 4-chamber view. We can make 2-chamber view like echo. We can see 3-chamber view, and we analyze different part of cardiac segments from different views. Quantitative assessment is also very much possible. So if you have very poor echo window, patient is not fit for MRI. MRI is not available in Bangladesh either. But for the cardiologist in England or USA, we can give absolutely a very, very good functional information, as good as MRI from cardiac CT. So we can definitely request for cardiac CT for cardiac function. And that's how we do it. Exactly the same way we do in cardiac MRI. We just need the software, and everyone has got the software. So when to do cardiac CT? When I was preparing the slide this morning, I was thinking how to communicate with the with trainees. Why do we do cardiac CT? Because not many trainees in Bangladesh is familiar, I think, with cardiac CT. So what I did, I just copied this. So if you can see, this is my list from day before, 57 patients. I took the patient information out, but the indication, you can take a picture of it. You can see the indication. So lots of coronary scans, a few calcium, coronary calcium scan. Coronaries are for high-risk patients, low-risk patients, difficulty in breathing. So lots of sorts of patients we have got. Some heart failure patients to exclude ischemic heart disease. We have got TAVR planning CT, some pulmonary vein CTs. You can see for atrial fibrillation patients, pre-ablation, you need to exclude cardiac thrombus or plan, show them the anatomy of the pulmonary vein. So all sorts of reasons we do it. It is a very busy slide and very difficult to read. So I just summarize in 4 points. So why do we do cardiac CT? Calcium scoring we can do. We can do angiogram that is with contrast. So calcium score is a non-contrast scan. That's what we do first, and then we give contrast, okay? So with contrast, we can look at native coronary arteries. We can see the revascularized arteries like previous stented artery or CABG. Pre-procedure planning. Pre-procedure, it may be valve surgery, it may be from cardiothoracic surgeon, or it may be from EP guys who does a lot of EP procedures. So pre-procedure planning to see the anatomy or to exclude coronary artery disease. And post-op complication is another one. So I'm just quickly showing that's how we do calcium score. You can see coronary calcium. And then we score. This is a semi-automated method. There's some automatic method as well. We use machine learning or algorithm to do it automatically, but anyway, you can do manually. And this is how you do. So you consider each vessel and put some color there. The score is automatically done. You can also do aortic valve calcium score. If on echo, this is indeterminate severity, then aortic valve calcium score will help you to as an additional point. I'm not going to go there today. This is an overview. So then we give contrast, and that's how we do coronary angiogram. But what I want to show is it's going very fast. But if I stop there, this is the right coronary artery. In terms of anatomy, the left coronary artery is there. I have got pretty pictures later on. And what we can do is we can do carved plenary format. So we can manipulate this is the raw data. We manipulate the raw data into different reformat. This is called CPR or carved plenary format. We use it, look how cool it is to look inside the coronary arteries. You can see the lumens well, and you can see from every angle possible. So you can do volume rendered images. These are very important for surgeons when they want to see anomalous coronary or what is the course. We don't diagnose any disease from this as a radiologist, but or cardiac imager, but we can do these kind of images as well. So I will not waste any more time. I'm going to go to the cases. I've got a few interesting cases, and I thought this is going to be an overview session. So mixture of cases, surgical and medical. I'm going to do a series of cardiac imaging learning journey. So there will be 8 to 10 series. So I will go specifically with specific disease pathologies on those sessions. So this is an overview. So first case is this patient is a 58-year-old female. She came last year. So this is the last year case, but actually this is my last week's case. All the cases I'm showing are original, and I was the first reader. And within last 1 or 2 months, I would say. Most of them are from last week. So this is 58-year-old female who presented with chest pain, and troponin was, really, really enormously high, right? So 2000, this is high sensitivity troponin, by the way. The normal range is, I think, less than 6 or 10, something like that. So really high. So what are you going to do with this patient? I know everyone's answer is doing coronary CT, coronary catheter angiogram. Sorry. That's what we did. So, or the cardiologist did. So you can see the left-sided system. There is, for the trainees, there is probably some mild pathologies, nothing significant on the left-sided system. I'm going to show you, I'm going quickly because there was nothing to see on that one. So the right-sided system, so right coronary artery, what you can see, there's some linear problem there. Sorry, why it went there. So what I wanted to see on the show on the static images is there's a linear defect. This one had contrast holding. Anyway, so it was diagnosed as right coronary artery, distal right coronary artery dissection. So this is the dissection flap. She was managed conservatively, and she was fine. So last week, when I encountered her, she represented with chest pain. Yeah. Now, again, very severe chest pain. ECG is non-specific. Of course, it's not ST elevation MI, but because of her history of SCAD or spontaneous coronary artery dissection, this time she underwent coronary CT angiogram. I want to quickly show you. So this is what we found this time with some pericoronary fat stranding as well. So this is a new dissection she developed. So this is a recurrent dissection, but this time is an LAD. And we looked at the right coronary artery. It's mostly fine. There's a faint line. Probably it's very difficult to see on your screen. But if you see it on PACS monitor, it's quite obvious that there's a flap. So the previous flap from 2022 is still there. It's non-obstructive, but now has got a new dissection in left anterior descending artery proximally. So next case is a 49-year-old who had a aortic valve replacement with a bioprosthetic valve in 2019 and presented with 1 week history of fever, chills, very classic history. He had been to dentist 4 weeks ago for cavities, but did not have antibiotic prophylaxis. So this can happen in USA as well. So axial images, I have got. So essentially, he had an echo. Sorry, I don't have the echo images. Echo is showing prosthetic valve endocarditis. So we do CT scan for prosthetic valve endocarditis to look at complications. Okay, so I will not scroll through that again. I have got some static images. So this is the prosthetic aortic valve. This is the valve vegetation in different planes. So this is axial. This is just oblique, coronal, and sagittal. So this is the vegetation that was floating, was seen on echo. What was not seen? Oh, okay. And there was a question about aortic root abscess as well. But on echo, it's not very clear or it's very difficult to see the extent of the disease process. So you can see around the aorta, the fat is stranded. So fat should be completely black like this. But here, there is a lot of stranding. So we call it aortic root abscess. Actually, it's not like, the definition we learn in surgical rotation that it has to be, there has to be an enhancing wall or something like that. This doesn't have a wall. This is like all phlegmonous infective material there. Sorry, there was a question I can see. Did we do a CT after coronary after angio on the first case? We didn't do CT after the cath because there's no point of doing a CT after cath. So the next time she presented, so she was managed conservatively with medication, and the next time she presented, they didn't do a cath, they did only CT. Sorry, back to this case. So this is what we can see, all these aortic root abscess. So for surgeons, it's very important to know how far it extended to. So this patient, I remember when he was having the scan, I think around 10 o'clock in the morning, 2 hours before that, he developed complete heart block. So for trainees, the conduction pathway goes through this part of the heart. And that's, I think, called fibrous trigon. And because the infection extended into that part, he developed heart block. So we didn't know about heart block. As soon as we saw the image, we called the surgeon and said, does he have heart block? And he said, yes, he developed this morning. So it's very relevant. The other things I want to show you is all these are phlegmonous material. So the extension you can see is along the coronary artery, causing some mild stenosis of LAD. So it is not confined to the aortic root. It extended along the coronary artery and caused some mild stenosis. So we assess the extent of infection, other valves, whether there is other vegetation as well or not, and also how the coronaries are looking, because probably this patient will not have a cath before going to theater or OR for the surgery, because it's quite high risk, right? What else this
Sadia, how
patient
well
had?
can you see the
So,
vegetation? Can I ask you? I'm sorry for the interruption. How
sorry.
well can you see
Yeah,
the
no,
vegetation?
absolutely.
itself?
Interrupt me.
So how well can you
How
see the
well can we
vegetation
see
itself?
vegetation?
Uh-huh.
Very well. Absolutely. It's just the technique is a bit different. So we do a higher dose technique and we image in systole and diastole. So imagine normal cardiac imaging is usually in diastole and maybe 60 to 80% of cardiac phase from RR interval. But if you ask for vegetation, we do full cardiac cycle and we up the dose to manual pulsing, we call it. So and you can see beautifully the movement of the valve, and that's how we assess how we assess all the valvular disease or valvular masses
So
or
when
any
we're putting an
tumor.
order, how
So
do you want to put the order in for the cardiac
just
city for
say
vegetation?
vegetation. So you want to see complication and you want to assess the valve. That's it. We protocol it. So I'm sure your hospital has got robust system, and it is beautifully seen. So as you can see, what I was showing you on other planes. So for radiologist or for cardiac imager, please look at your scan on every plane possible. So it's a volumetric acquisition. So you need to do MPR and see other planes. So this is the sagittal plane. You can see this vegetation or this infection, I would say, has gone into the RVOT and involving the pulmonary valve. So this patient will need pulmonary valve surgery. And all the cardiac imager knows that how difficult it is to visualize pulmonary valve vegetation or extension into RVOT of any infection or any pathology because of the window. So it's very important to say that because this patient will need extensive surgery. So pre-planning is very important before theater. So look at every angle and describe whatever. Sorry, Nasser Bhai, did you have any other question? Was it clear?
Yes, thank you. It was very clear. Thank you so much. Appreciate it. Thank
Okay.
you.
So the same patient, what we do if they ask for cardiac imaging for infective endocarditis, we because the communication system is quite robust, so we always ask whether you have got any question about the body, because patient is going to OR, right? Operating theater, I mean. So basically, if they say yes, has got a little bit of abdominal pain or something suspicious in the abdomen, then we do the whole chest anyway. So we do abdomen pelvis. So same patient who has got embolic infarct in the left kidney and spleen. So it's good to know for the surgeons as well. If the patient develop more pain, they know that probably throwing more septic emboli. So that patient had surgery. And surgery was done quite extensive clearance with pulmonary valve replacement needed, aortic valve replacement, aortic root replacement. So very extensive surgery. This is the post-op, immediate post-op film. I have got a companion case just to show you how difficult it is to see pulmonary valve vegetation. The people who are congenital heart disease expert, they know that a lot of congenital heart disease patients have got a really tricky anatomy to assess on echocardiogram, and they mostly get echocardiogram. I'm not talking about any MR today because it's not that available in Bangladesh. So this echo of the pulmonary valve, I've got only limited view. You can see something moving there. There may be something, patient has got symptoms. So there is a question of infective endocarditis. They were not sure. So this little thing can look like this on CT. So look how big this vegetation is. It's a massive vegetation involving his. So this patient's history is very young, I think 13 or 14. He had tetralogy of Fallot as a child and had extensive surgery. You know what surgery involves, VSD repair, pulmonary augmentation and all these things, and had a prosthetic valve as well, and has got this big vegetation in pulmonary valve. I just thought that I should show you. So next case, I'm going a bit quickly because I've got a very important message to give in the end, so that I want the participant to listen to that. So case
Sadia,
360
can I
cardio.
just
Yes,
can I just quickly interrupt? Sorry to interrupt. Very good
absolutely.
presentation
Interrupt
going on.
me anytime you want.
MR is actually present in Bangladesh. I think it's very underutilized. So I know there are a few centers, I think 1 or 2 centers where they're doing cardiac MRI. I mean, correct me if I'm wrong, probably my Spencer will know better, but there are in popular DSMMU, I think those places they have MRI machines.
No, only 1 or 2 centers are doing CMR. Machine may be present in
Oh.
many places, but only 1 or 2 centers. But
It's very
not widely.
underutilized. Yeah,
It is
Selim
not
bhai,
wi-
it's very
it-
underutilized.
Yeah, it is not widely practiced in our country.
Yeah, that's
Thank
why
you.
I'm just excluding MRI today, but I'll have a full session of cardiac MRI, and I'll probably be able to motivate some of you to do more cardiac imaging. And because the machines are there, you need only 1.5 Tesla. You absolutely don't need 3 Tesla machine, because even 3 Tesla machine is a nuisance because it causes lots of artifact. 1.5 Tesla, you just need the training, how to do the exam, and the what's called the software package in place, which every scanner vendor is happy to provide, and the training. So I will talk about cardiac MRI on a different session. So case 3, we'll go to case 3.
So-
Yes.
Can I
Please.
just interrupt? Just a quick question
Sure.
in regard to case 2. There's a
Sure.
question came into the chat box, like, can we do cardiac CT for endocarditis who cannot tolerate transesophageal echocardiogram? So in that perspective of question, do we know the sensitivity of vegetation detection by cardiac CT? For just to appropriately answer that question, is like, if we really think that, okay, we're suspecting someone has endocarditis, but patient cannot do transesophageal echocardiogram for various reasons, right? Many times we have, obstacle from our echo guys that, no, we cannot really do this transesophageal echocardiogram. And this sick patient happens. In that case, should we consider, or can we consider the cardiac CT, or we can sometimes know this is endocarditis, we just cannot treat it with antibiotics. So, one is blind treating, another one is trying to be more perfectionist. So what's this, is there any comparison between the CT detection versus transesophageal detection, or any sensitivity, specificity of?
I'm sure. Sorry. Thank you for the question. Very good question. We are asked by the cardiologist here as well, or cardiology trainees mostly. I have to read about it, but there are studies. I know that there are studies of this comparison, in particular transesophageal echo and for left atrial appendage thrombus exclusion, TEE, and cardiac CT. So we can talk about it on our next session. I will find out the comparison, but I can absolutely guarantee that you can do cardiac CT, and it's beautiful. The picture is beautiful. You just have to optimize the scan to look for it. It cannot be only diastolic or only systolic imaging, unfortunately, unless it is a big blob, like the cases I showed. If it's a small one, or any smaller ones, for cardiac mass like valvular fibroelastoma or myxoma, anything, you can do a cardiac CT. You have to just optimize the phases and the dose.
Yes,
Dr.
in my hospital, that is in Ibrahim Cardiac Hospital, I was doing a lot of cases of tetralogy of fallow repair and severe aortic stenosis, and many of them presented with visitations, mostly in the obstruction in the RVOT and in the pulmonary valve and part of the aortic valve. And luckily, and I'm fortunate that all those are depicted and evaluated by our radiology department very nicely. So it is nicely can be represented by the radiologist if they look at these images properly.
Exactly. Yeah, you have to have the training, of course, for the small one, but the big one is very obvious. The ones I showed you, I don't think any radiologist is going to miss this. Huge aortic root abscess and vegetation I was showing you. these big blobs of vegetations. But if it's very tiny, as I said, you need to play the movie. Sometimes it's difficult I think for echo as well. Difficulty is there when there is a prosthetic valve because there is a lot of streak artifacts usually. But we have got some metal reduction artifact software we can apply to reduce it. But still, if it's a mechanical valve around that, if there is infection, usually mechanical valve does not get endocarditis anyway. But for bioprosthetic valve or abnormal bicuspid valve, if there's a lot of calcification, it is sometimes tricky, but slightly larger one, definitely. Please do cardiac CT. You can detect it as the participant said. Sorry, I didn't notice the name.
May I ask one more question, Sadi?
Absolutely.
Okay, so just because Dr. Salim mentioned about that one point, and this is not about these cases, and since Dr. Shakil Bhai is here, as well as Jahangir Kubich. So I just want to ask you one quick thing. So when you go forward for your aortic valve replacement surgeries, do you mandatorily do a CT imaging of the aortic root to size the valve, or you just do it intraoperative measurements and go from there? What's the routine practice here in UK as well as in Bangladesh?
Mashrafi, thank you. Very good question. I think I will answer from the UK perspective. At least in our hospital where Sadia worked with us, almost 100% cases would get a cardiac CT. Because I think what happens is the patients present to the DGHS, local hospitals, and where a thoracic echocardiogram is done. Sometimes if you're lucky, a TOE is done, and I can tell you almost most of the time, the report will be endocarditis can't be ruled out. There's some thickening around the root and things like that. And no one will be brave enough to do coronary angiogram on that patient as well. So if they are coming for operation, almost 100% time, we shall get a CT coronary along with a full CT of the body, because as Sadia has said, there may be vegetations elsewhere, there may be problems with the kidney, and it helps us for the planning as well, because if you see that there's a lot of big abscess cavity around the prosthetic valve, mentally you just know that you are in for a long haul. You may need to do what we call a commander procedure, or we have to do a double valve replacement, something like that. So I think I would personally never go in to do an operation without a CT coronary or a CT scan. But obviously it depends on how fit the patient is and what the condition of the patient is.
And I want to
Thank you,
add
Kubich sir.
a point.
Yeah, I mean,
Shakil
right.
sir. Actually,
in Bangladesh,
perspective- sorry.
I'm sorry, I mean, in Bangladesh, what we do, if it is a redo AVR, we definitely do a CT angiogram and all, CT scan of the aorta and great vessels to see the position and all. But sincerely speaking, if it is a routine aortic valve, we normally do peroperative echocardiogram, that is T, not a CT scan for all cases, unless the aorta is too dilated and there is specific reason, valid reason for doing it. Maybe that is a shortcoming, but we don't do it.
But sir,
Like,
if there is endocarditis,
as Shakil said,
yeah,
we routinely. I don't think any other center Bangladesh, as we don't do, they do. I don't think.
No.
Sir, I want to add some point.
if there is
My
vegetation, if there is vegetation, will the cardiologist be happy to do a coronary angio? Because we do see that sometimes the cardiologists are reluctant if there's a big vegetation in the aortic valve to do an invasive coronary angiogram. I mean, I don't know, Jahangir sir can answer, or Dr. Nusrat Gofur can answer.
Yes, I want to add some point. In Bangladesh perspective, my center, Ibrahim Cardiac, some surgeon used to do aortogram. In fact, aortic root, they want to assess and take the all measurement before start valve replacement. Especially Dr. Salim is here. So he's used to do coronaries and also aortic root before start any operation. because there is a possibility of anomalous coronary artery. And also aortic valve replacement, he usually do aortic root assessment before surgery. না সেলিম ভাই আপনি এখানে আছেন তো না?
Yeah, I'm here. Before the MICS, I always go through the CT evaluation of the aorta and the sternum and everything, all the angles, all the distance and everything for both the mitral and aortic MICS.
I think for pediatric, it is necessary because you don't know when the LED is crossing the RVOT. And in that particular site, that for tetralogy of Fallot and where you do also for the aortic stenosis in pediatric, that is necessary.
For adult young
But-
prostitutes, Selim bhai
Sir,
usually used to do na aortic root.
So all the adult aortic valve I'm replacing by MICS, and mitral valve also be replacement by the MICS. I always go through this evaluation, CT evaluation. Without this, I can't proceed.
I think just to stay on that topic, I mean, MICS, I don't think anyone will do. If I do mini AVR, I never do it without CT scan. But if we
Yes.
just stick to the case that Sadia has given, endocarditis with a big vegetation of the aortic valve, do you think, Jahangir sir, that the cardiologist will be happy to do a coronary angiogram, invasive coronary angiogram in your center? Because the problem is you don't know whether there's coronary artery disease then if the patient is a middle-aged patient. So that's why we prefer to do a CT coronary, because it gives us that information about the coronaries as well as gives us information about the root.
Exactly,
So,
Shakil
I mean-
bhai. That's
Yeah, I
what I
agree.
wanted to add, that none of the patient go to the OR. In my experience, I'm sure there are a few patients, they don't come to us without a coronary assessment. So basically, if I summarize, what scan we do the coronary scan, as you need to acquire it. If you can give beta blocker, you give nitro. So you prepare the patient for coronary assessment, but you do the whole aorta. And also, if needed, the body. So you optimize the scan for coronary because that's the most motionless scan you need. And then you assess aortic root and the whole aorta, size it, because this patient might have severe coronary artery disease in terms of maybe cataracts. Sorry, I'm talking about cataracts, but severe occlusion or severe stenosis in one of the coronary arteries, which you may need to bypass. So none of the patient go without a coronary scan, basically, for these kind of surgery, complex surgeries.
All right, great. Thank you, Sadia. Yeah, let's talk
Shall
about
I
your third case. Yeah,
continue?
please. Yeah, sure.
To add that, the other thing on, like even routine patients without endocarditis, any valvular surgery patients have, if they have risk factors, even if some patients I will show without risk factors, they go through coronary assessment because it saves them a lot of course, time and money and also complications. So they go to pre-valve. The chart the list I showed you, the 57 coronary scans we did day before, a lot of them are pre-valvular surgery, pre-op coronary assessment, just to clear the coronaries so that they can plan whether they want to do CABG at the same time or they just want to go ahead with the valve because of very high negative predictive value of coronary CT angiogram. If I tell you that there is no disease, that means there is no disease in terms of obstruction. So next case, so we have gone away from endocarditis. This is kind of dual pathology, so I wanted to show you not actually surgical, but maybe medically relevant. So 65-year-old who has got known coronary artery disease, had previously had MI and PCI, presented with 2 days history of chest pain. His troponin was on the lower side. See the So this is the scan. So I don't want to go through that robustly, but there are, coronary artery disease. As you can see, he has got severe stenosis of the right coronary artery. So that's a severe disease there. And what else he has is almost similar appearance as our endocarditis guy. There's lots of stranding there. For cardiac imagers, please look at that space more carefully. So this patient, unfortunately, I missed it. So I didn't see those changes. I was it is called satisfaction of SARCH, SOS in radiology. That means I was very satisfied because he came in with chest pain. I have given him a diagnosis of severe stenosis of RCA, and I ignored the fact that, or I missed the fact that there are lots of soft tissue changes around this space, as you can see retrospectively where coronaries are going through. So this patient had intractable hiccup next day, so came back for a CT chest to see how the diaphragm is doing, whether there is something in the lung causing phrenic or nerve compression or something. So you can see the huge mass there, which I missed on the cardiac CT. So he went to get a PET after that, and PET was amazingly positive in terms of very PET-avid lesion near that aortic, on the right side of the heart, near the IVC. So that turned out to be myeloid sarcoma for this patient. So this patient has got dual pathology. So when you look at cardiac imaging, please look for other causes of chest pain as well. As I was telling you about cardiac thrombus, it's extremely sensitive and specific to rule out cardiac thrombus. You use it for, this is an 85-year-old patient who was having atrial fibrillation and was for EP procedure. So she was for pulmonary vein isolation procedure. And before that, you rule out left atrial appendage thrombus. So for the cardiac imagers or trainees, this is the left atrial appendage, and there's a filling defect there, and that's a clot, unless you do a delayed images. So this is the pulmonary vein phase where we want to delineate the anatomy properly, because you need to tell them whether there's any accessory pulmonary vein or not. It has got enormous implications. I'm going to do a session on EP, cardiac CT in EP procedures. That's a whole different spectrum of talk, basically. But if you do 1 minute delayed images, it's completely opacified. So this is not a clot. So I'm showing you the images where it looks like a clot, but if you do 1 minute delay, there is no clot. So we always do 1 minute delay for cardiac thrombus or cardiac tumor, because you never know this filling defect, what kind of filling defect you have. If it persists the same way, I had another image for another patient, sorry, I didn't include that. That was a big clot there. So these patients are not for cardioversion. So we get calls in the middle of the night, particularly for these cases who are unstable, need cardioversion. They cannot do a TEE to rule out thrombus. Do a quick cardiac CT, very quick scan. It takes probably 3 seconds to do. No preparation needed. You just need to give contrast, do a cardiac scan, ECG gated with a 1 minute delay, and you can exclude thrombus with very high specificity and sensitivity. So this is what we give for EP. We give the planning images as well in 3D volume rendered images. So I've got another case. This is a 49-year-old female with increasing dyspnea on exertion. We have got Meshkat pulmonary hypertension support group chairman probably. I specifically selected this case for you because we see these kind of patients everywhere. I saw it in UK, I see it in USA, who have been investigated extensively for pulmonary embolism. They get lots of CT scans because in this country it can happen. But no one could diagnose any problem except for, probably right heart pressure is increased. So this is a chest X-ray. The pulmonary artery is hugely enlarged. When I do face-to-face lecture, I always ask the trainees, what can you see? So the huge pulmonary artery, it's very dilated. So you know from this chest X-ray that this patient has got pulmonary hypertension. So of course, this patient had another CTPE in our hospital. So I want to show you, the first thing you notice is pulmonary arteries are huge compared to rest of the heart. Okay, the massive pulmonary arteries. There's no pulmonary embolism. What this patient have, I've got some static images. So first thing you notice is huge pulmonary artery. There's no embolism. We looked for it. Has got a huge ASD. So ASD is quite late diagnosed. I'm not going to go into pathophysiology. You are the cardiologists and cardiac surgeons, you know much better than me, but this is often misdiagnosed or very late diagnosed. And for the radiologist, what you need to see with that is association. So the most common association is an anomalous pulmonary vein, which this patient has. This right upper lobe pulmonary vein is going into the SVC. You have to tell the surgeons, although they look for it, but you have to tell the surgeons that there is an anomalous pulmonary vein going into the SVC, because they're going to do probably ASD repair and they need to know about it. So cardiac CT helps in looking for any associated anomalies patients have. So we diagnosed a few, at least ASDs quite late in life. This is a separate case. As I was discussing, it's very relevant. This is a 38-year-old who has got aortic valve insufficiency, very severe. So in our hospital, Dr. Bloom does lots of Ross procedure for this. We always get a coronary CT angiogram to exclude coronary artery disease. And who on earth thought about 38-year-old female with this really bad coronary artery disease? So this patient had CAD-RADS 4A, I think. In the USA, the cardiologist will understand the scoring system. I'll go through in detail on my next session, but has got very severe stenosis in at least 2 vessels. So this is the patient's CT. You can see the valve very clearly because we do, in our institute, we do systole and early diastolic imaging. And this is systolic imaging. You assess aortic valve mainly in systole because it should close. You can see the huge coaptation defect in the middle. So the cardiac imager, without echo, you can tell from CT that which patient has got aortic insufficiency. If there's any coaptation defect in systole, you straight away know there's aortic regurgitation going on. This patient also had aortic dilatation. I don't have the measurement here. I think it was 42 millimeter. I think the STJ is effaced slightly. So this becomes a kind of a different procedure, probably aortic valve and then root, and also probably bypass because has got severe stenosis. So this patient, of course, will have, because coronary CT angiogram has got slightly higher tendency to basically overcall most of the stenosis because of calcium blooming, which will go away when you get photon counting scanner, so with new generation scanner. But because of that, if we say there is severe disease, patient undergo catheter angiogram. But same patient, if she had only mild disease, non-obstructive disease, she will never get a catheter angiogram in this country because it's not necessary. It's very relevant to do cardiac imaging before proceeding to any valve surgery. So case 5 is a 47-year-old with known coronary artery disease. I just want to show you the images where cardiac imaging take a huge part in CABG, basically. So he had 4 vessel CABG. He's only 47. So you can imagine how high volume plaque burden he had when he was young. In 2018, he was much younger and presented with non-specific chest pain. So these patients don't go to cath lab at all. All of these patients get CT, coronary CT angiogram. Okay. So what I want to show you, yet, as I said, 4 vessel CABG, he had venous graft to RCA. He had venous graft to OM1 and venous graft to D1, and he had Lima graft to LAD. So this is the Lima graft. I just made some carved planar MPR because it's easier to see for you guys. So Lima graft is well patterned. So these are the clips, by the way. So Lima graft is well patterned, and the anastomosis and runoff is very well done. But look at the other grafts. There's no other grafts visible at all. So this is the graft to OM probably, which is proximally visible and completely occluded. So for the cardiac imager, when a graft is occluded, it disappears. So it just vanishes. So you can't see anything unless your doctor or the referrer gives you history that this patient had 4 vessel, 3 vessel. You probably can imagine from presence of clips. But you see, it has become probably fatty, like you can't see anything. There's no course of it. There was another one completely occluded. This was very cute because this is a stent in the graft, venous graft in RCA, which is completely occluded now. So you don't see any graft or anything. You just see the hanging, the stent hanging in the air, basically. There's nothing. So from the stent, this patient, we didn't have the history at the beginning. So a lot of patients come from different centers in our hospital, far away. So sometimes, and some from different countries as well. We don't have enough history of the surgery. So sometimes it's very difficult for cardiac imager to exactly say how many grafts they have. Imagine you're doing a cath on this patient. You would look for, you will do, spend a lot of time to delineate what are the grafts this patient had, and this patient has got chest pain. If I tell you this patient doesn't have any other patent graft other than Lima, and patient gets more chest pain tomorrow, probably you are going to take him to cath lab and do only shooting to the Lima graft. So that saves your time, that saves your anxiety, and that saves a lot of other what it is called, technicality around it in terms of post-procedure and peri-procedural complications. So I thought that the volume rendered images will be quite cute. So you can see the RCA, there's no graft. There are some lumpy, bumpy things in the aorta. And this is the Lima graft. So for the cardiac imagers, please extend your field of view to clavicles when you do cardiac imaging for graft patients. But that's very important. Otherwise, you have to give another dose of contrast, repeat the scan, which happens at least twice a year in my imaging center, because new trainees don't understand the implication of CABG and how the Lima graft comes from the top. So you have to specifically instruct the technician to get the, actually last weekend, I had exactly similar case. I told my trainee, I was a staff call, that please write down on your protocol that extend the field of view, and still it was missed. So we had to scan twice. But
Sadia,
in our
can I
center,
just make a
yes.
point? Yeah.
Sure.
Thank you. I think it's a very bad operation. Graft times 4 with 3 vein grafts in a 48-year-old. I'm sure Jahangir Kobir sir would never do an operation like this in a young patient. Now, from surgeon's point of view, I think it's always easier to look at the grafts when I get a CT coronary angio rather than a normal angiogram, invasive angiogram. So if a patient comes with a problem following graft, the first best investigation in my modality, purely from cardiac surgical point of view, is a CT coronary angio, because you can see the lie of the graft, you can see what's happening to what. Sometimes in coronary angio, it's difficult to understand what's going on because of what you have just shown. Thank you.
Thank you. So this patient, because we did full cycle, you can see how badly functioning the left ventricle is. He didn't have echo that time, but from qualitative assessment, we can say that the left ventricle is functioning very poorly, because you see the contraction is very poor. And he had preventative ICD in the right heart as well. So you can assess function if you need to, basically. Most of the centers don't do functional imaging, but if you ask for it, you will get it. So my last case is my quite favorite, because it was from last week, and I received a frantic call from the technician who was doing the scan. So this patient is 64. He's a male, presented to ED with sudden onset chest pain. He moved to America 4 years ago from Algeria and works as a butcher. His family history is unknown, but past medical history was only smoking was his risk factor. So he's 64. So to make it more believable, I just snipped the information I had on my EPIC system. And that's what it is written. I'm not an expert in ECG. I'm not a doctor anymore. I'm just an imager. So that's what it says. There's nothing significant there, but the troponin is rising significantly, right? So this patient will not get a coronary CT angiogram. This patient will go to cath lab. That's the standard. So went to cath lab. I want to show some static images first, because left-sided system and right-sided system were analyzed. They couldn't find the circumflex artery. So there's another image. So I copied and pasted that information as well, because who am I to understand the coronary cath angiogram? So what it says, what I understand is they tried several times. They shoot the aorta quite a few times, but just couldn't find where the circumflex artery is. They couldn't find the circumflex artery. So what did the plan? I don't know in Bangladesh what will be the plan. Probably cardiologists from Bangladesh can tell me, what do you do in this situation? Probably you manage medically, right? Because you cannot find that artery, but probably it's anomalous somewhere. But here we have got the option to do a CT angiogram. So that's the plan, was to do a CT coronary angiogram. And to take the patient to cath lab again, because patient was having excruciating chest pain. So basically, he was transferred from cath lab to our scanner. So I protocoled the scan, and the technician, when doing the scan, was calling me like, this patient is having really bad chest pain. What shall I do? Shall I continue or shall I send him back? I said, just continue, because they don't have the answer. We might have the answer. So we just quickly did the scan, because this scan doesn't take time. We didn't give beta blocker. He was on nitro already. And we did a CT coronary angiogram. So this is a volume rendered image for the non-imagers. So this is the right coronary, this is the left coronary, and we cannot see the circumflex artery. So this is the calcium score. So you can see he doesn't have much calcium at all. Probably calcium score was 1 or 0. And then he has got the right coronary artery. This is just static image, fine. And then left coronary artery, which is fine. We cannot see circumflex. So this is a coronal oblique image. So this is the right coronary artery coming from the, ignore this fuzziness. This is the phase of cardiac cycle where there was a bit of motion. But for the circumflex is seen originating from the right coronary sinus, which is anomalous because it should come from the left for the trainees. It's occluded basically. So I've got one more image. So if I show you on the axial images, so this is where the right came from. It's not at the same level. It came up first and then slightly inferior to it from the same right coronary sinus, the circumflex came. And it had a retroaortic course, which is an anomalous circumflex course, which is benign variety, which doesn't cause any problem, but it was completely occluded. So you cannot see any, even if you would scroll up and down. And there is reconstitution of flow distally. So this is the circumflex. So the reconstitution is happening from the right coronary system or left coronary system. So I've got some CPR as well. So these are the left and right coronary artery. This is the circumflex artery, which is completely occluded proximally. Okay, there is some pericoronary fat stranding, who the cardiologist and also the cardiac imager probably know. There's a very high risk feature. That means there's acute plaque rupture. So I'm showing you a very close view of fat stranding around the occluded vessels. So it was an acute plaque rupture causing complete occlusion, most likely. Okay, I said most likely because I had to go through the same scan with 5 specialists. They came down and it took half a day for me probably, and I was very behind with my reading. So basically what happened, his aorta was abnormal. So as you can see, there is what I thought initially whether the patient had dissection or not, what is causing it. So for the imagers, I want to tell you something. Please, when you see a disease, don't stop there. Just think about the cause, because finding the cause is very important for the patient management. So try to find the cause. So we always try to find a cause. Is it atherosclerotic cause of occlusion, which looks acute, or is it thromboembolic disease? So I was looking for clot in the left side of the heart. There was none. Is it dissection causing it? What is causing it? So his aorta was abnormal. So I was not very sure whether it's normal appearance of atheroma or not, which looks slightly atypical, very low attenuation and looks like thrombus. So I said mural plaque / thrombus because I don't know what it is, because non-calcified plaque can look like that. So, and also the aortic wall was a bit thickened. It is not dissection because he had in places with interruption. So you can see around the aortic root, this is ascending aorta and going up as well. So it's not a continuous thing. Aortic dissection is usually either focal or it continues up or down. So he had complete vasculitic screen. As a part of that, he had so all the vasculitic screening bloods are negative. And then we did body imaging. So when we say, exclude vasculitis as well, because that should be in the differential. When you're sure it's not dissection. Number 2 is whether it's thrombotic occlusion or not. So any thrombus. Number 3, vasculitis. So you do vasculitic screening of the rest of the vessels. In the abdominal aorta, you can see that he has got similar plaques. So this is nothing new. So it's most common things are common, right? So this was atherosclerotic occlusion with acute plaque rupture for his coronary occlusion. So you can see the atheroma. So he underwent a PET CT scan as well. That's kind of part of vasculitic imaging process. A vasculitis imaging process was seen by vascular medicine people, and he didn't have vasculitis. So it is completely atherosclerotic cause. So that was my last case. Any question about the last case? He went back
Hello.
to the cath lab because of severe chest pain from CT scanner. But because of the location and because it was completely occluded, I think there's a time difference as well. So he was managed conservatively.
No, Sadia,
So
এখানে
occlusion of
what you said that intervention cardiologist didn't find the LCH, right? And then the patient come to the CT room. But in Bangladesh, at least in my center, same things happened when they didn't find any vessel or when they find extra vessel like coronary cameral fistula or AVM, any sort of. Then they send to the patient in my CT room because my cath lab and CT room is side by side. So another information I want to add, my center and most of the radiologists or cardiologists who are doing cardiac imaging, they use CADRET. In each and every cases, we use CADRET. This information only for cardiologists from here, Bangladesh, and also USA. We are doing this. Thank you.
No, that's fantastic to know. But in England, we didn't use CAD-RATs, and most of the areas, apart from I think Scotland and Northern Ireland, in United Kingdom, England, I didn't see anyone using CAD-RATs last year. I don't know this year, but we'll talk about CAD-RATs in details in our next session, because next session will be in November. That is going to be solely on atherosclerotic cause of coronary artery disease. Okay, so what I wanted before the participants leave, because it's already 1 o'clock, I think, my time and 11 o'clock your time, is testing for coronary artery disease for the trainees. There are a lot of names you will hear and you will be puzzled, what to do, when to do, why to do, and why am I doing this? Like today's conversation was all about coronary CT angiogram. A lot of other testing are available. You will come to know. I'll be doing series of sessions, so I will explain. And what you need to decide is what does the patient need and what is available. So I just want you to remember this. Probably it will be useful for future. So how it happens when there is ischemia, this ischemia cascade, I think keeping it in mind is very important to decide on the tool you want to use. Okay, so that's how it happens. So if you see ECG changes, that's quite late in terms of time frame. Chest pain is very late, and then infarction happened at the latest stage of the disease. So first one was perfusion problem. So that's why we do lots of perfusion imaging to see perfusion defect. And if you want to look at ECG and chest pain, those are very later stage of ischemia cascade. So you need to remember this before deciding on the tool of imaging. I just want to show you only this slide. Our next session will have lots of data. So it's just I want to these are the studies, very important to know, because I know you're very try to be up to date with the guidelines and everything, but to know why am I doing a test is very important. So coronary CTA has got extensive, very high prognostic value. So this study was on this graph, this Kaplan-Meier curve is on obstructive, non-obstructive, obstructive disease, and this is on vessel involved. So it's kind of how many vessels and what is the plaque burden. And on both bases, the survival benefit is huge, as you can see on this graph. So there have been many studies showing that cardiac CT is a coronary CT angiogram, particularly very important because it can exclude disease. Inclusion wise, it overcalls sometimes, but it can exclude disease. So the guidelines have changed over the years. In UK, it is there since 2010, but they changed it to 2016. 2019 ESC took it in guideline, and America, I don't know why it is so behind, but it incorporated into the guideline in 2021 and gave it a class, sorry, it's a bit hazy slide, class 1 recommendation for coronary CT in stable chest pain, no known coronary artery disease. You do clinical assessment, intermediate, mediate or high risk patient get a CT coronary angiogram. So very straightforward. The CT coronary angiogram, I don't know how many patients you are doing cath on. Probably 50% will not need a cath. You can exclude disease if they're intermediate to high risk and stable chest pain. This is the CAD-RED score. If you can take a picture and have a look at it, but we'll explain in detail next time, and we'll go through some FFRCT information as well. What is that? But the last thing I want all of you to remember is calcium score. I am a big fan of calcium score. So these two gentlemen, Arthur Agatston and his name, oh my God, it's not coming, Genwith, Warren Genwith. So these two gentlemen in 1990 developed this scoring system, but unfortunately their paper never got published because it couldn't show relevance to coronary artery disease because there was no study. After that, there have been a lot of studies, particularly to mention MESA and Birmingham trial, where you can see that the benefit of calcium score, the prognostic implication is huge. And there's a term called power of 0. So if you have a calcium score of 0 for the coronaries, the 10-year mortality is less than 1%. So it's a very strong predictor of future cardiovascular events. So this is how we do calcium score. I showed you. But what I want to finish with is calcium score of 100 doesn't mean anything at all. You need to put in perspective because it is different in male in terms of risk, in men and women. It is different with age, different with different in ethnicities. In Bangladesh, we don't have to think about ethnicity, but here we in the UK we have got multi-ethnic society. So this multi-ethnic society study, we use this MESA calculator. Is available online. If you do calcium score in Bangladesh for any coronaries, please use it. Because I don't want to go through detail. Look at this 45-year-old male with calcium score of only 10. Where he lies, he's got 83rd percentile of risk. And 75-year-old with calcium score of 10, where is he? Probably 12, 15, right? So that makes a huge difference. If you put age and gender in consideration for our country, there's no ethnical consideration usually. Then you can see, and you can show this to your patient, show that, you are at a higher risk. So, be compliant with your statin. Our statin is not working. I'm going to higher up the dose. Sorry, I have got, why this slide moved. So it's extremely important to do calcium score. For the trainees, calcium score doesn't need contrast. Calcium score is very easy to do. You don't need any patient preparation in terms of, you don't have to think about renal function. You don't have to think about beta blocking nitro. You just need an ECG gated cardiac scan. That facility needs to be there. And I think it can be installed in most of the scanner available in Bangladesh now. So the picture of these precedents I put for a specific reason. I'll tell you why, is 2 seconds. I have to just get the bottom of it. This guy is very well, I'm sure. The picture of the presidents. So first one is Bill Clinton, and then Bush, and then the next one is Barack Obama. So these guys, I had the calcium score for them, but I can't find it now. Give me 1 second. I'll try to find their calcium score. Very interesting to see if I can find. So it's available online. I haven't stolen from anywhere. So Bill Clinton had a normal perfusion study during his regime, quite a lot, I think 5 or 6, and then needed 4-vessel CABG. when he was a president. George W. Bush, initially his calcium score was quite low, so he was on statin for a while, and then I think 7 or 8 years later, he had a PCI from MI. Barack Obama, he was a smoker in the past, but even if he was a smoker, his calcium score probably is 0. I think it's 0. It's online. And he falls down like very low risk category. So he doesn't have to be that compliant with his statin even if he has got hyperlipidemia. So it's very good at risk stratification. I basically ask everyone I know, family members, friends, this is offline. Have you had a coronary calcium score? Have you had a coronary CT angiogram? Because that makes a huge difference. It has got mortality benefit. It prevents future MACE. So what did we see to finish with? We saw a few cases of coronary artery disease. Why do we need it in EP, valvular heart disease, endocarditis, and so on. So we will have some future sessions specifically for those diseases. To take home points for the radiology trainees is look at anatomy. Very carefully, even if you are not doing cardiac imaging, even if you are scanning a patient for thoracic disease or abdominal disease, there will be always a bit of heart in your view. So look at the heart, look at anatomy, and also look at calcium. Comment on calcium, please. Anyone scan any part of the body. If you see a bit of heart, just comment on calcium, highlight in your conclusion. That's what we used to do in England. We always highlighted calcium. I think we do it here as well, but I do mainly cardiac imaging because this patient can be saved from a major cardiac event in future if you optimize the lifestyle and also preventative therapy. Also look for prior infarction because that may be cause of an arrhythmia in future. So you can see MI very well in any type of cardiac imaging. Look for thrombus because it can give a stroke. So this patient may have chest pain for some reason or abdominal pain for some reason, has got a big clot in the heart, which patient goes home and 2 days later come with a stroke. So you can prevent a stroke if you look for thrombus. Look for infection and tumor, of course. For the non-radiology trainee, the message is please think about the cause of the problem and then best possible investigation. I'm talking a lot about cardiac CT, but I know that it is not available everywhere. If it is available, please use it and consider non-invasive coronary imaging when possible. And I'm not going to say anything, but please consider being a cardiac imager. It's very important. Coronary artery disease is the major cause, a main cause of death worldwide still now. So if you're a cardiac imager, you can help a lot of it. It's in preventative medicine now. It's not only cardiac scan cannot treat a patient. Of course, we cannot put a stent. There are limitations. You need the imager to be well trained. There has to be a very low inter-observer or intra-observer variability. We have to have a robust scan planning or technique to do it so that the cardiologists believe the cardiac imager that what you were saying is right. When I say there is no obstructive disease, there is no obstructive disease. I don't have to ask the patient to pay twice. So $100 for coronary CT angiogram and $200 for Bangladesh, like 10,000, 20,000 average price of coronary CT and cath. So that they don't have to pay twice. You can get a very good image if you optimize the scan technique, technician, and the field of view. Last but not the least, cardiac calcium score can save lives. Please think about cardiac calcium score. It's very easy to do. It is available in Bangladesh, and use it as much as you can. Use it for yourself, for the relatives. I'm over 40, so I haven't had it yet, but probably I should. And encourage everyone to use it because I will show you what prognostic benefit it has in my future sessions. To motivate you a little bit more probably. And it's very easy to do. It's automated tool. You don't have to think about the scan at all. You just do the scan. The machine can give automatic score and you can add it to the risk stratification tool you use. I don't know which one you use. Whatever scoring system you use to put the patients on preventative therapy, adding calcium score is hugely beneficial. I'll show you in my next lecture. Thank you.
Thank you, Sadia. Thank you so much. Just one quick thing. তুমি 3 প্রেসিডেন্টের ক্যালসিয়াম স্কোর পেয়েছো, যদি ট্রাম্পটা জানতে পারো আমাকে জানিও। I'm very much curious to know.
I can tell you now actually. I just
So,
have to find out.
কয়েকটা question আছে আমি আমার panelist যারা আছেন আমার honorable panelist here তাদেরকে একটু ইনভলভ করছি এই ডিসকাশনের মধ্যে। একটা কোশ্চেন এসেছে দুজনের কাছ থেকে, ডক্টর সুভাষ বেদি and Dr. Mahbubul Alam. Is there any role of cardiac CT in the coronary microvascular dysfunction? So,
Absolutely not. I can tell you. So I am going to answer this straight away, saying that there is none at this moment, but we don't know what future holds. And that is one of the limitations of coronary CT angiogram. I am going to talk in details about coronary CT angiogram. Today, I was mainly giving an overview for everyone that what you can do with a cardiac CT, but there will be a dedicated talk next session in November. Please join, and then we can discuss in details about that.
Thank you. So, to answer that, no, it's not really possible to do microvascular by the CT yet. Nowadays, we do this cardiac FFR, which is coming, and in fact, it came to, at least it's done in our center. Definitely, CT FFR is done, but in future, maybe there will be like much more modification and sophistication to have that. But still, microvascular dysfunction is not
Mashrafi.
possible by CT yet.
Sorry, Mashrafi, was someone asking about CT FFR?
No. I was just saying that, যে CT FFR চলে এসছে, কিন্তু ভবিষ্যতে হয়তো আরো মডালিটিস আসবে, কিন্তু এই মুহূর্তে আসলে microvascular dysfunction cardiac CT দিয়ে করতে পারি না, সেটাই এটা। আমি হাফিজ ভাইকে দেখতে পাচ্ছি। আসসালামু আলাইকুম হাফিজ ভাই।
হ্যাঁ, সরি আমি একটু লেটে জয়েন করছি, আমার ছিল, কিন্তু সাদিয়া থ্যাংক ইউ সো মাচ, গ্রেট প্রেজেন্টেশন। একটা জিনিস আমি ক্লিয়ার করতে চাই, সেটা হচ্ছে যে সিটি FFR, it will probably give us some physiologic insight about the macrovascular stenosis, but the question was microvascular. So we are doing like CT PET, and the PET actually is giving a lot of insights. And Sadia probably will be the perfect person. We are using that myocardial flow reserve, some sense. So CT basically at this point, practically speaking, is all about anatomy. But if we combine this with the physiology, in future, we'll get a lot of information when we combine the technology for the functionality, not only for macrovascular, but also for microvascular issues.
Thank you, Hafiz Bhai.
Yes.
I just want to add some point. CTFF, I had lots of slides. I had probably hundreds of slides, but we cannot cover today. I know this question will come. You can probably show my screen. Can see my screen? Can you see my screen?
Yes.
Yeah, I've got a CTFFR slide. So we use it. We used to use it in England as well. It's quite expensive now, but anyway, price will come down. For the people who are not familiar, it's a science. It's kind of an art, I should say. I'm not going to explain in detail what it can do, but if you are aware of FFR, invasive FFR is just the alternative to invasive FFR is done by CT. The imaging we do, coronary CT angiogram, we send it to a company called HeartFlow. I don't have any share to that company, but this company processes it and sends us saying if the lesion is indeterminate in terms of moderate stenosis or single vessel severe stenosis, we send it, and then they give us the number almost similar to invasive FFR, and the revascularization planning is done from there. So it has got a very huge impact on management of patients, and which patient will go to CAT and which patient will not. I'm not going to talk about today, but it is going to come on my next session for sure in details.
It is approximately $2,000, not even what at this point.
But this is the company.
Yes, it will come down.
The images too.
Yeah.
But it will come down because the competitor, Deep Vessel Analysis, has got the FDA approval now. So it's going to be on site. So in Bangladesh, if we get a good scanner, and this vendor, then you can do the FFR on site and you don't have to send anywhere, and it is definitely going to be cheaper. So I'm
Yes.
going to talk about it on my next session.
Thank you, Sadia. Thank you, Hafiz Bhai. মেশকাত স্যার, আপনাকে একটু ডিসকাশনের মধ্যে নিয়ে আসতে চাচ্ছিলাম। স্যার, আপনি যেহেতু পালমোনারি হাইপারটেনশনের লিড পজিশনে আছেন, বাংলাদেশে পালমোনারি হাইপারটেনশন এর ক্ষেত্রে কিরকম এখন আপনার ইমেজিং স্টাডিজ ব্যবহার হচ্ছে পালমোনারি হাইপারটেনশনের ম্যানেজমেন্ট অথবা ডায়াগনোসিসের ক্ষেত্রে?
Well, VQ scan, there's nowhere in Bangladesh people does the VQ scan. We have CT pulmonary angiogram. On the other day we were talking about the role of CT angiogram in compared to that of VQ scan, and I was talking about that if you really good at CT angiogram and if you can detect some subtle changes in CT angiogram that can be equivalent to VQ scan. So I was eagerly looking at at Sadia whether our CT guys have some interaction with her and can develop that skill, because now and probably in near future we'll have little VQ scanner in the country. Not in the country, actually. If you look at the region, only a very few centers do that VQ scan. So for that reason, I'll be looking eagerly to the expert interpreter of cardiac CT scan in regard to pulmonary embolism. We do a lot of echocardiograph because that is what we really do have. And at the time, they give some good clue. Today, Sadia was talking about the patients with shortness of breath. And just in the last week, we could detect 2 cases of pulmonary embolism. And we could detect the emboli by our echocardiograph, transthoracic echocardiography. Later, they were confirmed by the CT angiogram. And one of our patients happened to be a gynecologist, and she had to undergo for thrombolysis with RTPA. She's doing fine nowadays, and it was diagnosed within 3 or 4 hours after she had developed the shortness of breath. So we have CT pulmonary angiogram, and it is of some use, especially for patients with pulmonary embolism, because probably we have much more cases of pulmonary embolism, especially subtle pulmonary embolism, minor pulmonary embolism that are undetected. So the CT scan is going to be of some help. I was thinking about the CT FFR, and if you allow me to make some comment on CT FFR. We are at a time being very attracted by the new technology, especially the upcoming new technology. But I have some reservation about FFR, because FFR is originally being designed from the non-invasive imaging. The design of FFR, invasive FFR, was based on non-invasive imaging, and now we know that the non-invasive functional imaging at a time missed some cases of coronary artery disease who later present with acute coronary syndrome. So probably FFR, I'm not really sure, is going to be of that help in finding out the patient, proper patient whom we should defer doing the intervention. So we should be a little cautious about this FFR.
Definitely. Thank you.
Actually-
I just
Thank
want
you,
to
sir.
comment.
In case of
Sorry.
pulmonary hypertension, Mashrafi said what imaging can help. In my experience, when a young patient with shortness of the breath or postpartum young female, usually cardiologists used to do pulmonary angiogram, and there's a very much possibility there's a embolism in pulmonary artery and distal vessels also. And the last 3 years during COVID era, there is a loss of patient pulmonary embolism causing pulmonary hypertension, and we are used to do pulmonary angiogram, right, Sadia or Ajay? I think this
yes.
information is correct, right? Thank you.
Can I add something with Dr. Mishra, sir?
Sure, Ajayda.
Okay, actually, from the recent study of ischemia trial, now functional imaging, especially stress imaging, is going down and down. Nowadays, anatomical imaging is more and more important, especially CT, changed the paradigm into different ways. So, though FFR is very popular to know, but its use, if you look at the chest pain guideline in stable angina, its use is very much limited in particular points. And it is that the FFR positive does not mean that this patient should undergo revascularization. It is the anatomy and it is the severity of angina which will dictate which patient should go under revascularization. So FFR can identify the culprit lesion and can explain the intermediate lesion which can produce symptom or ischemia, but it do not dictate indicate the revascularization process. So I think that nowadays functional imaging is going down, rather anatomical imaging, especially CT, is coming out, especially in the ischemic trial. It well focused. Thank you.
I have a quick question to Nusrat Appa and the went on perspective from Bangladesh. তখন
ভালো হয় মাশরাফি মাঝখানে কেটে গেছে মনে হয় আনস্টেবল নেট কাইন্ডলি আরেকবার রিপিট করেন
না মানে আমি একটা কোশ্চেন করছি আপনাকে এবং যে বাংলাদেশের এবং ইউএস পার্সপেক্টিভ ফ্রম এখন সিটি স্ক্যানে পাচ্ছি my image particular logic team that the heart rate is low. I cannot do it. I cannot do it, and give more beta blocker. But patient is sick. Other possible things. Blocker, and they are already hypotensive. Would be acceptable to the brain.
আমি কিছু শুনতে পাচ্ছি না সমস্ত কথা
বোঝা যাচ্ছে না মাশরাফি খুব
কেটে যাচ্ছে
কোশ্চেনটা কিন্তু ক্লিয়ার
কেটে যাচ্ছে
তাই নাই
I'm sorry.
Probably talking about if the patient is compromised, blood pressure low or heart rate problem, whether we can still do CT coronary or not, right?
সাদিয়া তুমি একটু ক্লিয়ার করো আমার মনে হয় হার্ট রেট রিলেটেড গেটিং প্রবলেমটা বলতেছে তুমি একটু ক্লিয়ার করো যে হার্ট রেট কত হার্ট রেট তুমি চাও এবং role of beta blocker IV or PO before the procedure. I think he's probably asking that.
Okay, so most of the scanners are single source in Bangladesh, and diastolic imaging is preferable because of the speed of the scan. Diastolic imaging, so if you see in cardiac cycle, diastolic images is not static. So if the patient has got irregular heart rate or very high heart rate, the first phase change is in diastole, as far as I understand. So it's not static. So we optimize the scan to be, if the heart rate is below 60, that's preferable. So it can be beta blocker at home. Some people take it at home before. So when you prescribe it for cardiac imaging purpose, you can give it at home, oral. Sometimes some hospital has got the policy to give it when the patient arrives, so one dose, and then wait 1 hour and then get the scan. If needed, they give IV beta blocker. Hospital Packport, where I used to work, we used to give IV beta blocker for every patient. So we optimize it below 60 so that we can get good diastolic phase of imaging. In terms of gating, as I said, we can do prospective or retrospective. It usually depends on the person who is imaging. Most of the time, retrospective is preferable because you can get multi-phase of images, and if coronary is blurred in one phase, you can get away with it because you can change the phase and look at it. Prospective is usually step and shoot method, so there is no overlap. So usually, if it's non-diagnostic, it's non-diagnostic. In this hospital where I work, I was amazed to see they do systolic imaging only, no beta blocker. So I want to show you a slide. I was so fascinated that I made a poster out of it and presented in SCCD. So can you share my screen? See my screen, sorry.
Yes.
Yeah.
So
Yes.
systolic imaging without beta blocker, reduce the slot
Make
time
it
from
full
30
screen,
minutes to
Sadia?
20 minutes. Sorry.
Sadia, can you make it full screen? Your
Oh, yes, I can.
just-
I can make it full screen. Yeah.
Yeah.
So I was showing the scaling happening in this institution. So we use a hub and spoke model. So we sit in Boston in MGH. We have got all these scanner. The farthest one is Martha's Vineyard, I think on Nantucket Island. So there's a scanner there. They scan the patient and they send the images there. We do the checking. We check every image is performed because it needs to be repeated. It should be done at that time. And I don't think there is much cost on implication if we repeat the scan. So if it is suboptimal, we can change the parameter. I will go through everything on next session because that will be dedicated to coronary imaging. But you see how we are scaling it. So for example, when I started in September last year, if we did 25 scan a day, it was a busy day, but now we do almost 60 patients a day on an average. So the reason we can do it is we can sit in one place and we can review the images. There is only nitroglycerin needed that is done by the nurses because nitroglycerin will dilate the vessels, but beta blocker is not needed. But the only caveat to it is we have got dual source scanner everywhere. So when you have dual source scanner, you can do it in systolic imaging. It's very fast. You can acquire the image in 0.5 seconds. Papworth has got dual source scanner, but they don't like systolic imaging yet. I think it is just being used to it. So yes, you can get away with different heart rate. And also if you have irregular heart rate, you acquire, you do more padding. So rather than 60 to 80%, you can increase the acquisition over a longer period of time. So there are techniques if you cannot control heart rate.
অ্যাকচুয়ালি সম্ভবত মাশরাফি জানতে চাচ্ছে যে বাংলাদেশে আমরা আসলে হার্ট রেট নিয়ে কি করি। আমার সেন্টারে আমার মনে হয় এট দিস মোমেন্ট হাইয়েস্ট নাম্বার অফ করোনারি করছে ইব্রাহিম কার্ডিয়াক। আমাদের যেটা হয় সেটা হচ্ছে ও যেটা বললো রেট্রোস্পেক্টিভ এবং প্রসপেক্টিভ এবং কি হার্ট রেট আমি মেনটেন করি। আমার সেন্টারে আমি হার্ট রেট মেনটেন করেছি 75 থেকে 60 এর মধ্যে হলে আমি করি এবং বিটা ব্লকার ইউজ করা হয় ইউজুয়ালি 50 উইথ চেকিং আফটার চেকিং ব্লাড প্রেশার। কোনো আইভি বিটা ব্লকার ইউজ করা হয় না কারণ আমাদের ওরকম সুপারভিশন নাই এবং ওরকম সিপিআর ট্রেনিং নাই যে কোনো একটা কিছু হলো আমরা কিছু করব এটা। আর হচ্ছে বেশিরভাগই রেট্রোস্পেক্টিভ ইউজ করা হয় কারণ আমরা মাল্টি ফেজে ডায়াস্টোলিক সিস্টোলিক ইউজুয়ালি 75% ডায়াস্টোলে আমরা ইমেজটা করার চেষ্টা করি বা সবচেয়ে ভালো দেখি। আর প্রসপেক্টিভ আমি আমার প্রেজেন্সে যখন দেখি ভেরি স্টেবল গুড হার্ট রেট উইথ এক্সপার্ট, আমার সব টেকনোলজিস্ট এক্সপার্ট তিনটা বা চারটা রেট্রোস্পেক্টিভ করি। এট দিস মোমেন্ট প্রেজেন্ট সিচুয়েশনটা বাংলাদেশের এমনই। ইব্রাহিম কার্ডিয়াক, আমি অন্য সেন্টারের কথা বলতে পারছি না,
Really good.
এখানে আমার সবচেয়ে হাইস্ট নাম্বার কার্ডিয়াক মিটিং হয় যতদূর আমি জানি এট দিস মোমেন্ট। থ্যাংক ইউ।
Thank you,
Mashrafi, we've got a small quiz session for the trainees. Shall we round that fast before continue with the discussion?
Sure.
আমি একটু অ্যাড করি একটু
Buddy.
হাসান স্যার আগে আমি একটু বলি আমার অভিজ্ঞতা থেকে। নুসরাত যেটা বলছে ওকে ফাইন, এটাই মোস্টলি প্র্যাকটিস করা হয়। আমার অ্যাভারেজ হার্ট রেট থাকে 60 to 65। আমি যেহেতু আমার নিজের পেশেন্ট, আমি বিটা ব্লকার অ্যাটলিস্ট বিডি ডোজের দিয়ে পরের দিন সকালবেলা আবার দিয়ে আমি এটাকে নিয়ে আসি যাতে স্টেবল থাকে। এবং যাদের অ্যাক্টিভ অ্যাজমা আছে তাদেরকে তখন বিটা ব্লকার দেওয়া যাবে, সেক্ষেত্রে ইভাব্রাডিন ইউজ করে আমরা। যদি হার্ট রেট বেজলাইন হার্ট রেট 75 এর উপরে থাকে সেক্ষেত্রে 15 মিলিগ্রাম স্ট্যাট দেই, দেন 40 মিনিটস ওয়েট 1 আওয়ার ওয়েট করার পরে দেখি। আমার টার্গেট হচ্ছে 65 ইজ দ্য গুড ফর 128 স্লাইস, এই আর কি।
ইট ডিপেন্ডস যে পেশেন্ট ব্রেথ হোল্ড করতে পারলো কিনা, ইয়াং কিনা, কত এক্সপার্ট। যেটা সাদিয়া বলে যে টেকনোলজি এবং অ্যাকুইজিশনটা কখন হচ্ছে, কিভাবে ট্রিগার হচ্ছে, এটার উপর ডিপেন্ড করে। যেমন আমি 75 এ, সামটাইমস আমি 80 তেও কিন্তু ইয়াং পেশেন্ট, ইয়াং মেল পেশেন্টের খুব গুড ইমেজ পাই, কিন্তু ইট ডিপেন্ডস। আবার ফিমেল ইয়াং সে শ্বাস কেটে দেয়, এটা ডিপেন্ড করে আসলে। যেহেতু আমি রেডিওলজিস্ট প্রেজেন্ট থাকি, দ্যাট টাইম ডিসাইড করি যে কোন পেশেন্টের কোনটা আসলে প্রোটোকল ইউজ করা ভালো হবে। Thank you.
তো ব্রেথ হোল্ড খুব ভেরি ইম্পর্টেন্ট ইস্যু আর কি, ব্রেথ হোল্ড অনেকেই করতে পারে না, যে কারণে ব্লাড হয়ে যায়।
Especially
রেট ইভেন
female.
75-এও ভালো হয়, 75-এও ভালো করা যায়, বাট ব্রেথ হোল্ড যদি ঠিক মতো না হয় ইভেন 60-তেও ভালো আসে না। আর ডেটা যদি ভালো না হয় ফলস রেজাল্ট আসে, সেক্ষেত্রে খুবই ডিফিকাল্ট রিপোর্ট করা, এবং কার্ডিওলজিস্টরা তখন খুব অ্যাংশাস হয়ে যায়, যেটা মিলতেছে না আমাদের ক্যাথের সাথে। সেই জন্য গুড ডেটা অ্যাকুইজিশন ইজ ভেরি ইম্পর্টেন্ট, যেক্ষেত্রে
One
getting
point
এবং
is
হচ্ছে
important,
ব্রেথ হোল্ড।
what Sadia said, the training and expertise in case of cardiac imaging is very important, training, because this is not like other cross-sectional imaging, other radiology, general radiology. It's something different from general radiology.
Thank
So
you.
probably we
Thank
can
you.
do the
Sadia,
quiz session
wanna-
quickly, right?
Yeah, let's go ahead with the quiz. Yeah. Toma, can you please check on that? Like when someone is answering, just keep a tally of that so we can later on send the prize to the right person.
So much of you, while they're putting the quiz, the CTFFR, we cannot use that in acute coronary syndrome because there's a lot of issues. And then second thing is that ischemia trial was exclusively in stable coronary. So I don't want to go into the debate about which one is better. But the question is, what is the question we are asking? Are we asking a question? Somebody has a CAD, or we are asking somebody has a prognostically significant disease, excluding left main proxial AD. So you need to decide as a clinician, what is the question we are asking? And therefore this topic today, the title, it is technologies all are complementary to each other. It is not rivaling one over the other. So, and then pulmonary embolism, exclusively doing pulmonary invasive angiogram is not routine. Even in the US, we are doing it CT first, unless there is a massive PE and coding situation. And then after that, thinking about invasive versus lytics or anticoagulation, not routinely doing pulmonary angiography for pulmonary embolism, not a good strategy.
I just want to add on that. If you suspect, if patient comes with chest pain, shortness of breath, you are not sure whether it's pulmonary embolism or coronary artery disease or aortic dissection, it's very easy to do a triple rule out scan. So one scan can answer everything.
Right.
So
Yes, there's
please keep in mind.
Word, not
And
triple
we
rule
will
out
go
in
through
acute
the
chest pain.
we'll
Acha,
go through
we'll
go to the technique next week. Next session, but it's very much possible to do, and we do it at least twice a week.
All right. I think we have some answer for the question 1. Let's want to go to the
Okay.
question 2.
Question 2.
So for your first question was, a lot of people answered definitely the right thing. So I think Tama, just keep a track on that, please. Who is winning in our sessions, please? All right, go to the question 2, which is, do I need contrast for the calcium score CT scan? I think we have some answers, right? Sadia, we got the right answer. No, we do not need contrast for calcium score for coronary. So this is the third question, right?
Yes.
Does this cardiac CT imaging shows
This is
Right,
the
I think-
aortic valve, and these are the coronary arteries.
right? So we have really
They've got the answers probably. Has got
Right, we got the
calcification in both. That's correct. Most of you are correct.
Thank you everyone for joining this quiz. শাকিল ভাই কিছু বলতে চাচ্ছিলেন মনে হচ্ছে, সরি আপনাকে আসলে বোধহয়
না আমি জাস্ট কুইকলি দু একটা পয়েন্ট আমার মনে হয় হাফিজ ভাই একদম কারেক্ট পয়েন্ট বলছে ইসকিমিয়া ট্রায়াল আই থিংক উই হ্যাভ টু ডিফারেন্সিয়েট যেটা স্টেবল করোনারি আর্টারি ডিজিজ এবং দেয়ার আর লটস অফ ক্রিটিসিজম অফ ইসকিমিয়া ট্রায়াল এটার মিন ফলো আপ ছিল অনলি 3.2 ইয়ার্স সো আন্ডার 5 ইয়ার্স কোন ট্রায়ালের উপর বেসিস করে উই ক্যানট সে যেটা প্রগনোস্টিক্যালি কোনো ডিফারেন্স নাই ইন্টারভেনশন আর নন ইন্টারভেনশন ইন করোনারি আর্টারি ডিজিজ এটা হলো 1 নম্বর পয়েন্ট 2 নম্বর পয়েন্ট হচ্ছে যে these were highly selective group of patients এবং এদের মধ্যে অনেক পেশেন্ট ছিল যাদের কিন্তু সিমটম অ্যাঞ্জাইনার একেবারেই ছিল না স্টেবল অ্যাঞ্জাইনা আর একেবারে না থাকা there is a difference আর ফাইনাল ইম্পর্টেন্ট পয়েন্ট যেটা ছিল 40% of the patients were diabetic yet only 20% of them underwent CABG we know from all the studies we have seen যে multivessel disease with diabetes CABG is better than PCI. There are lots and lots and lots of trials. Anyone will agree with me. So one can argue that those patients who had 40% of those patients who had diabetes mellitus did not undergo the right treatment. 80% of them underwent PCI. So I think we need to make sure that we understand those things when we talk about the ischemia trial. Second point, Hafiz bhai jeta bollen je pulmonary embolism niye. আমার মনে হয় pulmonary hypertension we have to identify what type of pulmonary hypertension we are talking about type 4 যদি স্পেশালি হয় যে বারবার ইয়ে হচ্ছে মানে ডিভিটি হচ্ছে পি হচ্ছে সিটি is the first thing that I would do আমার মনে হয় ক্যাথেটার ইয়ে ইমেজিং করে তারপর ক্লট সাক আউট করা there is no evidence there is some evidence on the literature যে catheter guided suction যদি করা হয় massive clotted from PE তাহলে তাদের রিকভারিটা একটু কুইকার হয় কিন্তু there is no prognostic benefit on that so most of the centers কিন্তু catheter ইয়ে করে না তাই either thrombolysis আর যদি thrombolysis সম্ভব না হয় কোনো কারণে পেশেন্ট খুব আনস্টেবল right heart strain তাহলে they undergo surgery so আমার মনে হয় we have to be clear what kind of pulmonary hypertension we are talking about and the third point I want to make is CT coronary তে কোনো prognostic benefit আছে নাকি microvascular dysfunction এটা একটা মানে খুবই গুড কোশ্চেন একজন সাদিয়াকে করছিল actually there is some indication and we did a study from Oxford which has been published in the Lancet I was a very peripheral person in that trial all I did as a surgeon was provide the left internal mammary artery part of it and some fat so ওখানে ওরা যেটা করছে রেডিও ট্রান্সনামিক সিগনেচার ইউজ করে CR19 এস একটা সিগনেচার পাথওয়ে আছে ওইটা দিয়ে তারা কম্পেয়ার করছে যে লো ইনফ্লামেশন আর হাই ইনফ্লামেশন আইডেন্টিফাই করতে পারে নাকি সিটি করোনারিতে এবং যাদেরকে ওরা লো এন্ড হাই গ্রুপ আইডেন্টিফাই করছে তাদের আর্লি আউটকামে কিন্তু প্রগনোসিস ডিফারেন্ট ছিল সো আই থিংক ইটস আ ইনিশিয়াল ওয়ার্ক lot of work needs to be done but that is the future the microvascular dysfunction will be identified by doing that আমি পেপারটা শেয়ার করছি এখানে কেউ যদি পড়তে চায় thank you but fantastic session by Sadia and really interactive session it's a shame যে Asif had to leave Asif is one of the cardiologists from UK who does a lot of CT angio and things like that so he wanted to contribute but I think he's on call so he had to leave early thanks everyone
Thank you, Shakil bhai. Jahangir Kobir sir কি আছেন? দেখছি।
থ্যাংক ইউ সাদিয়া মাশরাফি এত নাইস ডিসকাশন আমি মনে হয় অনেকদিন দেখি না মানে পার্টিসিপেট করি না খুব ভালো লাগলো থ্যাংক ইউ সবাইকে শাকিল
Thank you আসলে আসলে রাত হয়ে গেছে অনেক বাংলাদেশেও আমাদের এখানে বেলা এসেছে So I think if there is no more question, আমরা এখানে আজকে হয়তো শেষ করব. I just want to thank all my panelists to join and participate with this lively discussion, and definitely thank you, Sadia. You opened up a lot of our eyes on a lot of things that that was not really known to us. We would like to have these sort of sessions, interactive sessions, which are probably more helpful for us to learn new things.
So there will be more sessions on cardiac imaging. There will be a series. So this was part one of the series. There will be at least 10 more sessions every couple of months. So please join. And then we can discuss on dedicated diseases. Like first one is going to be, of course, coronary artery disease. And then we will talk about non-atherosclerotic causes and EP, utilization of CT and EP. So a lot of relevant things. And most importantly, it has to be relevant to Bangladeshi doctors. So we will keep that in mind and we'll discuss a lot of conversation about CT-FFR, but I think we first have to establish cardiac CT, a robust system in Bangladesh. And then we can talk about utilizing other technology and the cost implications, of course, for the patients, because it's not cheap. So, but we have to start at some point, and then probably we can acquire all the latest technologies possible. And thank you so much for supporting me and joining. Thank you, Mashrafi, for giving time to be a moderator in a combined session.
Thank you very much.
Sadia, thank you. At least popularize calcium score to start with.
আপনারা সবাই ক্যালসিয়াম স্কোর করেছেন তো?
সাদিয়া, আমি অনেক ক্যালসিয়াম করতে দেখি।
এখন ম্যামোগ্রাম আর কোলোনোস্কোপির মতো আমাকে জিজ্ঞেস করতে হবে সবাইকে ক্যালসিয়াম স্কোরটা করা হয়েছে কিনা। আর ইউ অন স্ট্যাটিন?
সাদিয়া, ক্যালসিয়াম স্কোরের ওয়ারেন্টি হলো 10 বছর। যেখানে অন্যান্য
is enough, right?
For 10 years, you are sure that you are going to live for more than 99. There is chance of living more than 99%.
10 বছর পরে সিটি করোনারি করে নিলে হবে। 10 বছর তো যাবে ফার্স্টে।
মিশকাত ভাই, আমি আমার পার্টনারদের বলি যে ক্যালসিয়াম স্কোর যদি 0 হয় আর যদি রিস্ক ঠিকমতো কন্ট্রোল, তাহলে স্টার্ট ডোনেটিং অ্যালজাইমার্স ফাউন্ডেশন, বিকজ ইউ উইল নিড দ্যাট।
কিন্তু শাকিলের সাথে একটু ডিফার করে আমি বলতে চাই, মানে আমাদের ইসচেমিয়া ট্রায়াল যেটা বলতেছে, ইসচেমিয়া ট্রায়ালকে কিছুটা যদি বিশ্বাস করি, তাহলে more and more will need calcium scoring than anything else. Only thing that will
আমি 100% for calcium score, but then ischemia trial কিন্তু অনেক criticism আছে, and we should know what exactly it means and কেন প্রবলেম গুলো হচ্ছে। 3.2 years median follow-up দিয়ে I do not think we can come to any conclusion. I mean, this is what happened in all the PCI versus CABG trials. যে initially খুব short term ভালো রেজাল্ট দেখা গেছে, and everyone thought CABG is going to stop. But then when we followed up after 5 years, things changed completely. And I think that's what's going to happen with ischemia trial. I mean, Hafiz bhai je point make করতে,
আমি যেটা বলতেছি যে শাকিল এবং মিশকাত ভাই দুজনকে একলে যে খেলা শুরুর আগে ক্যালসিয়াম স্কোর, খেলা শুরু হয়ে যাওয়ার পরে ইসকেমিয়া ট্রায়াল, তখন it is different story.
Absolutely
Right.
Hey, trial, primary prophylaxis aspirin use, these are like so misinterpreted in our community practices. It's really
You're right. Yeah, thank you. Excellent.
উইনার কি এখন ইয়ে করবে? উইনার কি এখন
আসলে তমা এটাকে ইয়ে করবে।
এটা তো অ্যাড্রেস গুলো লাগবে যারা
আমি একটা উইনার পেয়েছি আসলে তোমার কাছ থেকে, সেটা হচ্ছে ডক্টর মোহাম্মদ আলাউদ্দিন is the quiz winner.
আচ্ছা, ডক্টর আলাউদ্দিন কি এখানে আছে?
ডক্টর আলাউদ্দিন, Dr. Alauddin is the winner. Congratulations for listening and participating to our session. If you want to turn on your mic and your camera and just introduce yourself to us, that would be really, really appreciated. একটু জোরে বলবেন, আসলে শোনা যাচ্ছে পরিষ্কার।
Assalamualaikum sir, can you hear me sir?
Yes.
I am Dr. Alauddin. I am from Armed Forces Medical Institute. I am MD phase A training sir.
Thank you. Congratulations, Dr. Alauddin, for participating, and you're the winner. Toma, our PHA partnership from there will send you the prize for this quiz session. Please we will get in touch with you to get your address and everything. Okay.
Thank
you
you, everybody.
everyone আজকের এই সেশনের সবার পার্টিসিপেশন এন্ড কন্ট্রিবিউশনের জন্য আই থিংক ইটস গোইং কোয়াইট লেট এট নাইট এট বাংলাদেশ আমাদের এখানে দুপুর হয়ে যাচ্ছে তো সকলকে ধন্যবাদ এবং এই ধরনের সেশন আরো ভবিষ্যতে করবার আশা এবং ইচ্ছা রেখে আজকের মতো এখানে শেষ করছি সকলকে অসংখ্য ধন্যবাদ বাই বাই